Let's talk a little bit about rabies and the kinds of disease that it causes. We're going to talk about, the pathogenesis of the rabies virus. You've probably heard of rabies. It's actually one of the oldest known diseases. Rabies is also sometimes referred to as hydrophobia, which is really just a fear of water. And rabies originally comes from rabas, which means to do violence. And that speaks to the symptoms that either rabid animals or rabid people display. It was first described in 1546, long before Pasteur and Roux actually worked to develop the vaccine for rabies. So rabies vaccine was one of the very first vaccines that was produced. And that's because in the 19th century, here we're looking at an example, rabies was just everywhere. It was often known as canine for dog or street rabies, and this was especially true in Europe. You could see in the cartoon down below that it was just present everywhere. And the term was used mad dog, and that really was just because people were so very, very fearful of what would happen if they encountered a rabid animal. The World Health Organization today, currently, estimates that there are over 10 million people on a yearly basis that receive exposure treatment for rabies virus. We will see that we can actually prevent rabies virus from causing disease, and you can prevent it even after you've been exposed to the virus. So that's called post-exposure prophylaxis, or PEP. However, in spite of the fact that people receive this prophylaxis, there are more than 55,000 rabies-related deaths every single year, and that's really predominantly a public health concern in parts of Asia. Here in the United States, maybe 1 to 3 people develop rabies on a yearly basis. So it's not really seen so much here, but worldwide it's a big problem. And the reason that it's such a problem is illustrated in this little scheme here. When we look at the virus, rabies virus, like many viruses we will talk about, are actually maintained very happily in the wild. Maybe not happy for the animals that encounter it, but the virus really doesn't need to encounter humans at all. It can be very happily maintained in a life cycle where you have one infected animal, and that infected animal will spread the virus through a bite to another infected animal, and then that infected animal can then in turn spread to another infected animal. And this can be in wild animals, and that's how the virus is maintained in nature. We can have it spread to more closely related animals, close in terms of proximity to the human population, that is domestic animals, because these wild animals, if they encounter a domestic animal, can bite that domestic animal, and then we can begin to spread the disease. And that domestic animal then could, in theory, now encounter a human, or oftentimes what we see are just animals in the wild that are infected with rabies virus will now bite a human, and resulting in human infection. So rabies virus is a zoonotic infection that is spread from animals to humans. And the deal with rabies is that once you begin to experience disease, as illustrated by the person lying on the ground, this disease is invariably fatal. Rabies is the most fatal or deathly deadly, I guess I should say, deadly disease, viral disease that is known. If you experience symptoms of rabies virus, it's an almost certain death sentence. We'll talk about a couple exceptions at the end, but for the most part, that's a problem. Fortunately, we can prevent the progression to the disease state through that post-exposure prophylaxis. Once the human encounters the virus through a bite, and really it's primarily through a bite, aerosol is really, really rare. So it's really, you have to break the skin in order for that really to be able to come in contact with you. There's a pretty long incubation period, anywhere from 5 days to 2 years. Some says even 6 years. The incubation period can be very, very long for this virus. We've looked a little bit already at how the virus is spread in the neurons, but this gives a more complete picture in terms of what's going to happen with the progression of rabies to promoting a full-blown disease. Okay, so really the most common route is the virus is going to gain access to the body through a break in the skin. And that occurs because you are bitten by an animal. And the virus is released in the saliva of the animal and is deposited into your muscle. And what we see happening with rabies virus is that the virus is pretty happy to hang out here for a fair amount of time, and that is going to, the length of time that it stays in the muscle is really that incubation period. And the virus is just going to replicate there for up to weeks or even months, and it is maintained in these muscle cells by binding to the nicotinic acetylcholine receptor at the neuromuscular junction, as we've discussed previously. But then when the virus is released by the muscle cells and it encounters at the neuromuscular junction, then it can encounter the nerve endings, and as we've mentioned already, get taken up by binding to the NGF receptor on the neurons. And now the virus is going to travel along the axons excuse me, and make its way to the cell body, and that cell body is found in the dorsal root ganglia. So the dorsal root ganglia is the place where we find the cell body of the neuron, and there are lots of cell bodies. There are lots of neurons in a ganglia. So a ganglion is a collection of cells, and that will allow the virus then, once it replicates in those neurons, buds off of the cell body, it can bind to other neurons in that vicinity, in that dorsal root ganglia. The dorsal root ganglia is part of the peripheral nervous system, but it sends a branch or a connection into the central nervous system. And once it's into the central nervous system, here in the spinal cord, now the virus can infect motor neurons in the spinal cord, and as well as the neurons in the dorsal root ganglia, as we've already mentioned. But now we're into the spinal cord, and we're going to replicate in the motor neurons of the spinal cord. And the virus, once it's in the cerebrospinal fluid, it can very easily get up into the brain, and it can begin to infect the neurons in the brain. It can spread along the neurons that innervate all different kinds of parts of your body. We can see it sometimes getting into the eye. And then for it to be able to spread, what we're going to see is that the virus is going to spread along the nerves to the salivary glands, among other places. And the virus then is going to be released into the saliva, and the virus is present even before you begin to see signs and symptoms. And that's why even if you are bitten by an animal that doesn't appear to be rabid, that is, it's not acting all crazy, oftentimes that animal will be taken for observation because of the fact that the virus can be released before you begin to see the symptoms. So the virus is spread in saliva. It's in the saliva then, and that makes it very easy for when an animal bites you that it can now allow that virus to enter into your body. When we look at, again, just another picture of the nerve, but when we look at the virus getting into and replicating in the muscle, and then it eventually is going to make its way into the axons. And it's going to piggyback along the axonal transport system. We have a way to move things up and down our axons, and we know exactly how fast the virus travels, rate of 0.5 to 15 inches per day. Some of these axons can be really long. So the axon that's in your leg, for example, can be quite long, and well more than 15 inches. And we can measure then that rate at which the virus is going to travel. And therefore, it can take a long time before the virus actually gets into the central nervous system. That, in part, is why this post-exposure vaccination is possible, because it's going to take a while for it to get to the point where it's going to start causing damage, and we can be protected if we have antibodies that will help prevent the spread of this virus. We can also use this post-exposure vaccination because the virus actually hangs out in the muscles for a while before it actually begins to spread along the axons. And we need to make sure that we're trying to target it before it gets into the neurons, because once it's in the neurons, then it's kind of hidden from the immune system. But when we look at the virus, it can spread to lots of different tissues using the peripheral nervous system. As I mentioned, the virus is going to bud out of the salivary glands and exit via the saliva. So this slide just kind of summarizes stuff I've already talked about. When we look at the actual disease itself, it turns out that there's more than one form of rabies. We actually have two clinically distinguishable forms. The first is known as furious or encephalitic rabies, and the second is known as paralytic or dumb rabies. So colloquially, we just say, well, either you have furious rabies or dumb rabies. And with either form, you can have a long incubation period, and this is really the extremes shown here, anywhere from 4 days up to 6 years. That's pretty rare for it to be that length of time. Usually it's about 3 weeks post-bite that you will contract actually begin to see symptoms. And in both cases, what we're going to see is that eventually you either furious rabies or dumb rabies, the patients will enter into a coma, and then once they're in a coma, there's actually really no support. There's nothing but supportive care, and the time between entering into a coma and the patient dying is it's about 18 days, but that's going to be strictly dependent upon the kind of supportive care that a person receives. And when you're looking at trying to determine whether or not you should be worried about whether or not an animal in the wild has rabies, if they don't have a fear of humans, then that's something that you should be worried about, especially when you're looking at an animal that's normally active during the night. If they are present during the day, you should really stay away from them. Okay, we're looking at the symptoms during the very first part of the disease. These we call this a prodromal period. This is the start at which we're seeing initial signs and symptoms of the disease. And when we look at this list of the signs and symptoms, nothing really jumps out at you. You have a headache, you have malaise, you have fever, you could have a cold, right? Your stomach might be upset, you don't want to eat, and that's usually because your stomach's upset, or you could actually be vomiting as a result of this nausea. These are pretty generic symptoms, and that's a problem. As you can imagine, if someone has a really long incubation period, they don't remember that they've been bitten, or in a lot of cases, they don't actually know that they've been bitten, depending upon the source of the virus. And they present to the physician with these list of symptoms, and they might just think that they have a cold or the flu. And this prodromal period lasts for about 2 to 10 days. And then from this prodromal period, this is where the two different forms of rabies differ. So both forms of rabies, you will experience this prodromal period. And then in the case of the furious rabies, we begin to develop these secondary symptoms. And this secondary symptoms is often defined or called the sensory excitation phase. And this is where you now have all of these symptoms that you would associate with rabies. And that includes the fear of water, hydrophobia. And because of that, well, really the reason that you have this fear of water is because the virus can infect the larynx and as well as the salivary glands, as we've mentioned, and you get kind of swelling, and the muscles of the larynx begin to contract. You get these spasms, and it's really painful, especially to swallow. And that's where you get this classic kind of picture that you would have with a wild animal that is just drooling like crazy, hypersalivation. And that's in part because of these spasms that are happening in the larynx that is causing the patient to salivate at a really high rate, and then they don't want to drink because it's so painful, so then they have this fear of water. All that's kind of tied in together. All right, you begin to see other kinds of symptoms too. Patients are agitated, they're experiencing anxiety, they might experience hallucinations, lots of bizarre behavior, they're acting completely out of the ordinary compared to what they were before, biting objects, other animals, various kinds of contractions of the diaphragm, so that you're getting muscle involvement, and depending upon where that virus has landed in your body, then you can get these various symptoms. But all of these other kinds of symptoms, like the agitation, the anxiety, the hallucinations, the bizarre behavior, all that's due to CNS involvement. That is the central nervous system. Once the virus is in your brain, it's just wreaking havoc. In the case of the paralytic or dumb rabies, the secondary symptoms, that is, we're going from the prodromal period now into the secondary symptoms. There's no hydrophobia, no hyperactivity, no seizures. Basically, you just go from the prodromal period to the coma. And so that's going to be pretty severe, and these patients are going to die much more quickly than those that would enter into the sensory excitation phase. And when we look at the symptoms, we also see these applying to animals that are, and for whatever reason, animals that are normally predatory, they often will experience the signs of furious rabies, so that's a real problem because they're going to want to go and bite you. Whereas the animals that are non-predators tend to not display this. They could just go into that coma or paralytic phase of rabies infection. How do we diagnose rabies? It's kind of a problem for diagnosis. It's in the neurons, it's in your brain, and it's kind of hard to go in and just take a chunk of your brain out to test for the rabies. Most of the definitive diagnosis for rabies are going to occur after death. And that's in part because we can't get at the brain to test it. And a lot of times too, with the prodromal period, and even when patients are in that sensory excitation phase, because at least in the US, rabies is so rare, it's not often thought of as the first thing that physician would think of in terms of a disease. So what we'd like to be able to do, so antemortem, we're going to isolate the virus. And then you might think, well, okay, well, what's the point? The person has already died. Why do you really need to test the virus? Well, what happens is that following death, or even if you can get a sample, what you're going to do is perform a very sensitive assay, reverse transcriptase polymerase chain reaction, so PCR. And what that PCR is going to do is a very sensitive way to detect viral RNA. And we can detect that even when there's low levels. So in the saliva, if the virus is in the eyes, then it's going to be in your tears. If you do a spinal tap, you can get the cerebral spinal fluid, and you might be able to get enough to be able to do RT-PCR. And so why would we want to do that? Well, it turns out that certain strains of rabies are species specific. So if you have a patient that presents either with for example, like the paralytic or dumb rabies, they're not able to speak to the physician. They're not able to tell anybody where they might have encountered the virus, but it's pretty important to pinpoint the source of that virus. And because these strains are species specific, we can do PCR and we can tell whether or not this virus came from a bat or whether it came from a skunk or so on, any of the various sources, and that's going to be really important for trying to isolate that particular source. We also can test for the presence of antibodies, but these often don't appear until the second week of illness, and again, sometimes they don't appear until you won't be able to get them at all, and the patient will die. Sometimes what is done is to take a biopsy of the skin right at the base of the neck, so really close to the brain, and sometimes we can find the rabies antigens in the nerves right at the base of the hair follicles. In animals, the gold standard for testing is to measure the levels of the rabies virus using a fluorescent dye that is attached to an antibody that's specific for the virus. So this is called direct fluorescent antibody test, or DFA. This is done post-mortem. We can do it also on animals that are behaving abnormally and look for the presence of the rabies virus. Rabies is found in the nervous tissue. So obviously brain is going to be the best, and for looking for it in looking at post-mortem, then you would take either the brainstem or the cerebellum or the hippocampus, different brain regions. You would like to test a couple of different samples in order to confirm the diagnosis, because it's pretty serious. You want to make sure that you're actually identifying the virus. When we look at the presence of rabies in the wild, really it's primarily disease of the mammals, as we have discussed, and depending upon where you live will dictate the risk factor for the virus. And the virus is going to be, you have a great risk factor in different parts of Asia, and also different parts of Africa tend to have a much higher risk, South America. And not only do you need to look geographically at the risk, the overall risk, but you need to look at who should you be worried about depending upon where you are. So for example, and you don't have to memorize all of these, but for example, if you were to go to Asia or Africa or South America or Mexico, you need to be concerned about dogs. If you are going to Mexico or South America, then you really want to be concerned about vampire bats. Now you can see in this example that I just gave, South America, you need to be worried about not only vampire bats, but also dogs as well. And therefore you can look geographically and kind of get an idea as to the potential source of the virus in these different regions. In the United States, there are generally just a few sources of few terrestrial sources of rabies virus. And again, there is a distribution of this terrestrial source. We call these a reservoir, and that's a common term that we'll use in virology to talk about who might be housing the virus. And that's especially true when we're talking about zoonotic viruses. Who's the reservoir? Where does that virus like to hang out? And that's going to vary depending upon where you are in the United States. For example, if you are going out to lunch here in California and you encounter a skunk walking around during the daytime, stay away from that skunk, because skunks are nocturnal animals, and in California, skunks are the primary terrestrial reservoir for rabies virus. And if they're out during the daytime, that means something's not normal. There's not a good reason for them to be out, and you need to be concerned about rabies. If, however, you are on the East Coast, that extends all along the coastline, and again, you're out for lunch and you see a little cute raccoon walking around, you should stay away from it, because that could be a potential source on the East Coast. And so you have these different sources, and primarily we're talking about skunks. Those are the major sources. Fox, raccoons, those are, and there are different types of foxes. They're all any fox, but again, different regions you will see different strains of or species of fox. So there aren't that many animal or terrestrial reservoirs. It primarily comes down to skunks, raccoons, and foxes. Those are the major sources within the United States, and that's for terrestrial. But what we find is that there is a non-terrestrial source of rabies that is a really actually a large concern. Bats are an extremely prevalent source of rabies virus, and here we're looking at a distribution across the U.S. of rabid bats. Since 1990, more than 90% of the human cases in the U.S. have been associated with bat bites. And bats are really a big source, and again, really a potential for worry, especially because in many of the cases, the individuals didn't know that they were bitten. So they were bitten at night, maybe when they were sleeping, and the bat bite didn't leave a large wound, and it wasn't enough for them to think anything of it. And so now that could be a reason why the patients don't know that they have been bitten when they begin to present with these symptoms. But it's a big concern. Something happened, I think last week, I believe in Minneapolis, where there was an injured bat that was on the ground, and someone walked by and touched it or moved it and then left, and then a second person walked up and picked up the bat and called authorities and had the bat tested, and the bat turned out to be positive for rabies. Well, the first person had touched that bat, and it wasn't known whether or not that person was bitten by that bat, and they didn't know who that person was. It was just someone had observed this first person encountering the bat, and calls went, it was posted on social media, posted on the news, big alert saying, whoever walked by and saw a bat on this day, this location, please call authorities. And within a day or so, that person turned up. And that's because of this real concern for the fact that bats are the major source of rabies. So that person, both of those people, will now receive post-exposure prophylaxis, and hopefully that will prevent the disease. To try to get a handle on managing the rabies in the wild population, we began a concerted effort for vaccination, and that started in the 1940s and 1950s. If you have an animal, you have to prove that you have a current rabies vaccine for your domestic pets, and that's gone a huge way to decreasing the numbers of or the levels of rabies virus in the population. In the wild, though, we are also trying to decrease the levels of the virus in the population by distributing vaccines, and millions of doses of oral rabies vaccines beginning in 2003 and continuing on to try to decrease. And so these vaccines are in an edible form, and the wild animals will eat it, and then they can be protected from that. To manage human rabies, there are numbers of ways. The first and most traditional way that we think of preventing a viral infection is to deal with it before you come in contact with it. That is to use a pre-exposure. There is a vaccine, and this vaccine is given in 3 shots, and the vaccine is injected intramuscularly for several days, several time points. That usually takes, as we've seen in the case of immunity, at least a week to generate immunity. This immunity lasts a couple of years, and therefore you have to be revaccinated. Anybody who is at a potential risk of coming in contact with someone that might have rabies needs to be vaccinated. This would include obvious categories such as veterinarians, animal handlers, dog catchers, but mail carriers, laboratory workers, obviously, who work with the rabies virus, and anybody who might potentially come in contact with the virus will be vaccinated against the virus. Fortunately, as we've mentioned, you can have a post-exposure treatment. The first type of way to prevent the virus from causing an infection once you've come in contact with it is actually a rather simple kind of treatment, and that is just wound care. And the reason that this works is because once you come in contact with the virus is going to replicate right at the entry site. It's not being inoculated into the blood. It's going to stay in the muscle for varying length of time, but it's right there. Therefore, once you have been bitten, you can really wash the wound. And this includes washing with just soap and water, or you can use 70% ethanol or other kinds of antiviral agents that are going to attack the lipid bilayer. You could also use a virucidal agent like providin iodine that has also been shown to be helpful in just eliminating the virus right at the source of infection. Now, obviously, this would not be the only way you would treat the virus post-exposure, but it's the first step and can go a long way towards reducing the viral load right at the site of infection. The next thing that you're going to want to do post-exposure is to get some kind of treatment. Because it takes about a week for your immune system to begin to produce antibodies, and while that is fine for the most part, in terms of the fact that this virus has a relatively long incubation period, so average of 2-3 weeks, but that on the lower end of the spectrum, that incubation period can be as short as 4 or 5 days. That's not enough time to produce antibody. Therefore, in the post-exposure treatment, you want to go with the worst case scenario. That is, you want to start to protect the individual right away. And the way that we're going to do that is to provide antibodies in a pre-made form. And those antibodies in a pre-made form are called human rabies immune globulin, or HRIG. And really what these come from, they're antibodies that are made in humans. And really we just go to the people that have been vaccinated already, draw their blood, purify their antibodies. They're already making antibodies to the rabies virus, and that's the first treatment that you're going to be given. And this is going to provide this passive immunity to try to protect your body until your immune system can gear up and actually make the antibodies themselves. And if you have not been vaccinated prior to being bitten, you will receive immune globulin plus the vaccine on the first day. The vaccine, so you need to get vaccinated for the virus post-exposure, and the vaccine for many, many years was actually derived or had components that were coming from horse serum, and there were a lot of problems with the vaccine in terms of reactions that you would have. Now, what we use for the vaccine is a vaccine that's derived from growing the virus in cell culture. And that has eliminated a lot of the problems that were seen in past years in terms of bad side effects to the vaccination. So these cell culture vaccines are the ones that are going to be used for currently, and they're, as you can see from this table, and don't memorize this, but you can just see that there are a number of rabies vaccines that have been found over the years, and what you can see is really now they're grown in cell culture. Okay, as I've mentioned, if you don't receive the post-exposure treatment, or if you're not vaccinated and you're bitten by a rabid animal and you don't get any kind of treatment, chances are you're going to die from that. In fact, throughout history, there have only been 9 well-documented reports of people who have actually survived rabies. Now, it's important to note this is surviving rabies once they experience the symptoms, not after being bitten, just once after they receive the symptoms. And these were survivors of rabies, and these survivors of rabies actually got some kind of treatment. They got maybe pre-exposure, maybe they were vaccinated, but maybe it had been a long time since they were vaccinated, or they got post-exposure treatment, but maybe that post-exposure treatment wasn't fast enough or robust enough to fight off the actual virus. A lot of times, like, the incubation period can be really short if you, depending upon where you're bitten. If you're bitten in the head, then that deposits the virus right into the central nervous system, or it's much closer at least. Whereas if you're bitten on the ankle, then that virus is further away and it takes longer, and it's not as likely that you can get the central nervous system involvement. So a number of factors come into play even if you get a vaccination or post-exposure treatment. And of those 9 that survived, half of them had really severe neurological problems. It's not a good disease to get then, because you're not likely to survive. However, there was a report of a young girl in 2004. She was 15 years old, Jenna Geis, and she lives in Wisconsin. She became the first survivor of rabies virus to not receive any kind of treatment. She didn't get the post-exposure. She was bitten, she developed rabies, and she was able to survive. And she was able to survive because her physician used a treatment protocol that's now called the Milwaukee Protocol. So she was treated in Milwaukee, Wisconsin, and that's the name of this treatment. Jenna survived well enough to be able to go home, and she is, as I said, the first person in the world to survive without getting any kind of vaccine. And the way that she survived is because of this Milwaukee Protocol. And what the Milwaukee Protocol did was to use a combined strategy. What they decided to do was to basically quiet her brain by giving her a combination of anti-anxiety drugs to put her in a coma with the idea that it would protect the brain. And the two drugs that she was given were ketamine and midazolam. She was only given those for a short period of time, just for 7 days. And then at the same time, she was also given some antivirals, ribavirin and amantadine, along with very, very aggressive supportive care. By the time she was diagnosed with rabies, her physicians didn't have really, much of anything that they could do. They realized that she had rabies and knew that that was basically a death sentence. They began some quick searches and came up with this on their own. They came up with this combination of drugs, and they said to her parents, well, you can either take her home and let her die, or we can try this untested treatment in the hospital, and they chose that. After about a week, these anti-anxiety drugs were decreased, and then after that they discontinued the antivirals themselves. And this is kind of shown on this next slide. What they did was to use a combination of these 4 drugs that are shown in the bottom and highlighted by the circle around the title. And what they're trying to do was to try to do a couple of things. So they put Jenna into a coma, and they gave her ketamine. And what ketamine does is it's going to block the most common receptor in the brain. The brain uses a variety of neurotransmitters in order to communicate. And some of these neurotransmitters stimulate the target cell, and some of the neurotransmitters inhibit the target cell. Normally, the excitatory neurotransmitter is known as glutamate, and glutamate is going to stimulate cells, so it's called an excitatory neurotransmitter. What ketamine does is it's going to block this. So ketamine is going to block and prevent the glutamate from causing this, from stimulating the other neurons. So it kind of quiets the brain by quieting down and preventing this glutamate from doing too much. Glutamate is required. We use it all the time as an excitatory neurotransmitter, but if you have too much of it around, it can kill other cells, kill neurons. And by preventing glutamate from working, they thought, well, that's going to just keep the neurons from going around and hurting themselves. In addition to that, they gave midazolam, and this midazolam is a sedative that's really going to kind of just make everything quiet as well. But what it also does is, whereas glutamate is an excitatory neurotransmitter, there's another neurotransmitter called GABA, and GABA is an inhibitory neurotransmitter. And what the midazolam does is it activates the GABA. By these 2 drugs, then, they were able to decrease the actions of glutamate and increase the actions of GABA. And that's just going to try to calm the whole situation down. To try to fight off any viral infection, they gave ribavirin, and this was at the suggestion of the Centers for Disease Control. So once there is a reported case of rabies, then the Centers for Disease Control get involved in this. That is, they will be notified in the case anytime there's a rabies case. And these physicians talked with the Centers for Disease Control, and they talked to them about the potential treatment that they were going to use, and the CDC said, well, why don't you try ribavirin as well? And that's because it's a very good antiviral, and that is going to try to diminish the effects of the virus. And the fourth drug then that they used was amantadine, and amantadine was going to be added also because it helps to block the NMDA, the receptors. The receptor for glutamate is this NMDA receptor. It also then will inhibit the glutamate, but it works in different parts of the brain. And what they're trying to do was protect the entire brain. And really that's all they were doing. They were giving the antiviral, and they were trying to just quiet things down. And really what this was going to do was to try to buy them some time, to allow Jenna's own immune system to increase its activity. In this flow chart or timeline, what we can see is that Jenna was put into a coma for a very short period of time and was given these drugs right at the very beginning, and ones we've talked about, ribavirin, amantadine, midazolam, and ketamine. And you can see that they are used predominantly during this time when she was in the coma, and then they began to taper off these drugs. And what we begin to see is that during this time that she's in a coma, her body begins to produce antibodies. We can measure the total amount of antibodies, and as we've mentioned, that there are certain types of antibodies that are good at neutralizing, like IgG and IgA, and you can see that over time the levels of her neutralizing antibodies also increased. This happened in early October, and then following her coming out of the coma, by November, she was sitting up in bed. A few days later, she was standing. By almost December, she was able to feed herself and actually speak in a manner that could be understood. And by January 1st of that following year, she was able to leave the hospital. She continued on with her recovery. While she's made remarkable strides, there's still some long-term effects, but really they're pretty minor. She was able to graduate in 2011 with a biology major, and was able to meet with the person who devised the protocol at her graduation. I should say that Jenna was bitten by a bat. So she loves animals still, and when she saw a bat that was injured, she picked it up and tried to take it outside of a building, and at that point was when she was bitten by the bat. So they knew that, but even so, she knew she had been bitten. They still weren't thinking that she had contracted rabies, and that's why it took a little bit of time for the symptoms that she began to display for them to begin to really realize that she had developed rabies. It wasn't until she went to the excitation phase that they actually realized or began to think about the fact that maybe it could have been rabies. there was a tremendous amount of excitement with this Milwaukee protocol because here's someone who was able to survive. But unfortunately, in the patients to which this Milwaukee protocol has been applied in subsequent years, it appears not to be reducible. It's been tried in the United States, Thailand, Germany, India, and all of those patients still died after the protocol. And the question becomes, well, was there something different about the strain of rabies that she acquired? Was it attenuated? Was it not as virulent? But however, unfortunately, that question can't be answered because they never recovered any virus to test the hypothesis. And really, to do a controlled study, you don't want to just start testing on humans. They did this in this desperation case, but that's not really a well-controlled scientific experiment. You would ideally like to do this in animal research, to apply it to animals and test and see what works and what doesn't. However, there aren't a lot of schools that really want to have a bunch of rabid animals wandering around their units to really test this protocol. So because of the concerns with the virus, it really puts limitations on the ability of investigators to test out this protocol. But clearly this procedure worked in one person, and so it's thought that there's a potential there for it to be able to be used for other patients, especially in parts of the world where this virus is killing thousands of people every year.